Good afternoon, everyone, and welcome to this week's Decoding COVID lecture. As many of you are aware, the Warren Alpert Medical School of Brown University has set up this weekly lecture series over the course of the last couple of months in order to inform us all with the best science and the best tools with which we can combat the current pandemic. We're very pleased to have two of our leading pediatricians today speaking on decoding COVID in children. If I could have the next slide, please. With the title, Children Silent Victims of COVID-19. Next slide. This presentation is in accordance with the disclosure policy of the Brown University CME office, and speakers and planners have been asked to disclose any relevant financial relationships, and conflicts have been reviewed and resolved. Next slide. The Brown CME disclaimer and privacy policy is listed here. The CME office maintains its site as an information resource only. Next slide. This presentation is accredited for 1 hour of AMA PRA Category 1 credit and 1 hour of risk management credit. Next slide. Additional information about the CME archive. Next slide. When the seminar concludes, please email the Brown CME office with Decoding COVID in the subject, and you'll receive an email with a link on how to claim the CME credit. Next slide. Or if we could go to the first slide of the presentation. It's a real pleasure to introduce Phyllis Dennery. Phyllis is professor and Sylvia K. Hassenfeld Chair of Pediatrics. She's also professor of molecular biology, cell biology, and biochemistry, and pediatrician-in-chief at the Hasbro Children's Hospital. Phyllis has had a distinguished career coming to Brown from the University of Pennsylvania. In 2015, she's the recipient of many awards and honors, and particularly notable, she is a member of the National Academy of Sciences, the Association of American Physicians, and the American Society for Clinical Investigation. She's also principal investigator of a grant from the Idea State Pediatric Clinical Trials Network, supporting clinical trials to understand environmental impacts on child health outcomes. Phyllis is a member of the executive committee for the Hassenfeld Institute located at Brown. Michael Koster is associate professor of pediatrics. He's also a hospitalist and interim director of pediatric infectious diseases at Hasbro Children's Hospital and Rhode Island Hospital. He is leading the pediatric COVID-19 response for Rhode Island Hospital and Lifespan. He has a longstanding interest in viral respiratory diseases in children, including working in the area of pediatric global health and especially at a children's hospital in Haiti. I'd like to ask that during the presentation, if you have questions for the presenters, please enter them into the chat function, and we will respond to the questions at the end of the presentation. Without further ado, we'll hand things over to Mike, who will start out with this team production.
Great. Thank you so much, Sharon, for the invitation. It's my pleasure to be able to present side by side here with Dr. Dennery, my chair of pediatrics. And today we're going to talk about children, the silent victims of COVID-19. Our objectives today, I'm going to run through the first two, just describing what we've seen in children so far and touch a bit on the role of vaccines with respect to COVID-19. Dr. Dennery will assume the lead on discussing economic, social, and behavioral impacts in children, as well as those impacts in pediatric providers. So we know the world's changed a lot, quite a bit, and children are seeing that as well. One thing that hasn't changed is the resiliency of kids, and I put faces of these smiling children up there to all remind us of that. And we should always wash our hands. This has not changed. This is what my grandmother taught me before I even knew I wanted to be an infectious disease doctor. The phospholipid bilayer of the virus is exceptionally susceptible to soap and water, so don't forget to do that as often as possible. I start with this slide for a couple of reasons. One is we titled this Silent Victims. And this is a tweet that was sent out on March 27th, looking at the cases between Iceland and Netherlands. In the Netherlands, they were testing specifically people who had illness, who were sick, who were coming to the hospital. Whereas in Iceland, they tested broadly across their population. What we see here is a clear negative skew of the Netherlands data, which led many people to believe children don't get this illness. Children aren't being infected with COVID-19. And so this data specifically helped us understand that kids are getting the illness. And I think it's very representative in a visual standpoint and hopefully hooks you into the conversation. So in early data from China in February, they found they reported on pediatric cases there, and they found that kids accounted for approximately less than 1% of all cases in Wuhan. These were close to 2,000 cases. Most of them were actually suspected cases, so a good epidemiological link or family member who was positive. And 728 were lab confirmed. They found that most kids were aged 7 with an interquartile range of 2 to 13 years of age. And the vast majority of them had mild to moderate disease or even asymptomatic disease. The additional point that they made here was that infants seem to have higher rates of severe or critical illness. So that was 10.6% in that group under 1 year of age versus 7, 4, 4, and 3 for the other age groups. There was only one reported fatality in this cohort, and that was in a 14-year-old male. There was no additional information given if he had any underlying medical conditions. And it was also noted because in the adult population that there was a sex difference, that they did not see that represented in children. This is a slide just showing the distribution of pediatric cases in China. I think is especially important because at that time, it still wasn't clear what the route of transmission was. Was it droplet? Was it airborne? Was it oral fecal route? And this showed us that in the epicenter of Hubei and Wuhan area, that the vast majority of cases were there. You can see up in an upper corner an additional province actually where there's a winter festival that happens, that there was some spread there. But the majority of cases spread out from the epicenter, which highlighted the importance of human-to-human transmission. This is data from the United States, February 4th through April 2nd, which showed us that there were actually quite a number of cases in children reported in the United States, so 2,549 cases. And those cases, about 70 to 90% of them were from New York, New Jersey area. So this is during that outbreak in New York. And there were 3 fatalities associated with this cohort. So still a low mortality rate. This is data from that same MMWR report demonstrating the differences between signs and symptoms between kids and adults. So we see that the same symptomatology occurs in kids, but at much lower rates. So lower rate of fever, lower rate of cough, much lower rates of shortness of breath. There were also additional findings that were important at the time, including gastrointestinal symptoms such as nausea, vomiting, and abdominal pain. This is, sorry, I flipped this slide for you because it's very tall and doesn't project well. Over here, we have the age groups again, and along the top, we have the number of cases. And the key is here for ICU level care, hospital level care, or not hospitalized. So the majority and the vast majority of kids did not require any hospitalization or any hospital level of care. We see here also representation that many of the young children had admission for those that were under 1. This is pretty consistent with our experience here at Hasbro Children's Hospital, where we've had several what we call neonatal fever episodes, so kids who present with fever under the age of 1 month, and they need to be hospitalized for a presumed sepsis period of time for antibiotics until culture is clear. In addition to that, there was very little ICU level care for any of the age groups, and especially in the 1 to 4 age range. So China presented additional information as of February 26th. This time they're reporting 171 cases. There's likely some overlap with the original Wuhan report and cohort, but these were all confirmed cases. And I think what's important here to highlight, I put in red, was asymptomatic infection was fairly high at 15.8%. It's also notable that many of the kids had respiratory symptoms. We thought it was just a respiratory illness. And in fact, kids were getting respiratory illnesses, up to 65% of them. The clinical manifestations were not that dissimilar from those we had seen in adults. The ground glass opacities. This is in a 13-month-old boy, a 14-year-old girl, and a 15-year-old asymptomatic boy. So all of them showing these pulmonary findings, very similar to the adult findings that we had seen. So there were the clinical manifestations that were very typical. In addition, what was reported from China very early on was this idea of fecal PCR positive tests. So it's not uncommon for kids to have shedding of virus in their stool from all kinds of different viruses. And the original SARS coronavirus 1 did demonstrate fecal shedding as well. And so this was highlighting again that this was not just merely a respiratory illness. So I bring this slide up to show the varied and myriad examples of where surface receptor expression is in human cells. So we know in the nose and in the lung, especially when we think about the ACE2 or the TMPRSS2 receptors in the body. So many of the early reports describe this ACE2 receptor that allows for the viral entry into the cell. But we also know that in the gastrointestinal symptom, there are additional receptors for SARS coronavirus 2, as well as the heart, as well as in the eye. And you can see basically every organ of the body expressed here. We've seen cases of encephalitis. We've seen cases of kidney damage. And what's missing here is additional either bone marrow or hematological illnesses such as ITP. So in summary, the COVID characteristics in children is that they have equal varied presentations among adults and children. So it's pretty clear that SARS-CoV-2 is anything but simply a respiratory virus. There are all kinds of complications. Most recently, some of you may have heard about the amount of pulmonary emboli and DVTs, and especially thromboemboli that are formed during the illness. There are GI, as we'll talk a little bit more about cardiac illnesses, renal. I mentioned the encephalitis, ITP, and specifically febrile illnesses that we see in infants that often require hospitalization. We showed you that there's less fever and cough than in adults, and much less shortness of breath. at least 1 to 5% of all cases from reported countries and 1% of hospitalizations occur in children. So in many of the countries that have reported this, so China, Turkey, Italy, UK, and other places, including Iceland, we've seen anywhere from 1 to 5%. US represents the higher end of that spectrum at 5% in the MMWR report. About 10 to 25% are asymptomatic, so that's a very high number. I think it fits in with the rapid spread of the virus from what we've seen, that kids are not only susceptible, but they are acquiring infection and likely transmitting it even without knowing. The good news was that greater than 90% of these kids had moderate or less severe disease. And this US report from the MMWR through April 2nd confirmed 3 deaths amongst the 2,500 cases. That's in juxtaposition to the close to 50,000 deaths that had occurred in adults at that time. So bottom line here is that there's really no age range that's spared of the infection. We do see, however, kids having less severe illness. Well, what happened while I was preparing this talk? In New York and in Europe, there was an announcement. So this is the New York announcement that occurred on May 4th, that there is a pediatric multi-system inflammatory syndrome potentially associated with COVID-19. So at the time, there were 15 cases reported. As of now, there are 38 cases in New York City and 84 cases in New York State. And from personal communications with Dr. Dennery just before this, 4 cases they've seen at Boston Children's Hospital. So it's really characterized by prolonged fever and a syndrome that's similar to Kawasaki disease, which is an inflammatory condition affecting the coronary arteries of the heart. It comes along with a rash, conjunctivitis, mucosal changes, extremity changes, and often missing is a lymph node that occurs with that condition. What was surprising as well is a lot of these kids were presenting with fever, abdominal pain, and rapid deterioration. So they were either positive by PCR or negative. And the ones that were negative, many of them confirmed by serology, suggesting that it was happening a little bit beyond or after the actual infection with SARS infection. So this graph demonstrates that quite nicely. This is from England's Public Health, looking at the laboratory confirmed COVID cases in the blue line, and then this pediatric inflammatory multi-system syndrome, similar in appearance to either Kawasaki or Kawasaki disease, a lot of people call it when it includes shock, and as well as looking similar to things like toxic shock syndrome. And what this demonstrates is that it was quite some time after the cases that you saw this rise in this inflammatory syndrome. So the temporal association was there to alert everyone to be on the lookout. This does not confirm the association, but certainly demonstrates a temporal association. One of the most important things in an investigation like this is a case definition. So case definition for this is a child presenting with fever and inflammation and multi-organ dysfunction, and that child may or may not fulfill the criteria for Kawasaki disease. You have to exclude other causes, so staph or strep shock or other bacterial shock infections, or things like myocarditis from enterovirus. And what's interesting is because this is a delayed or immune reaction, the PCR may be positive or negative. And I think this is a call for interdisciplinary care for these patients between pediatricians, hospitalists, as well as rheumatologists, allergy immunologists, cardiologists, and intensivists. So as I mentioned, this case definition is really essential. Urgent evaluation in the ED is critical for vitals, for labs that support this, including things like a D-dimer, and also including things like interdisciplinary care. The treatment is treatment we understand and know well for shock. That's goal-directed care and ICU level care. There's a distinction out there between a distributive type shock from vasodilatation or a sort of septic appearance versus actual myocardial cytotoxic effects of the virus on the myocardium, causing myocarditis and cardiogenic shock. So there are differences in treatment for that really require close evaluation. Balancing antiviral and anti-inflammatory treatments is going to be critical. I list a couple of off-label use drugs here that you have probably heard about in the news. Remdesivir is a protease inhibitor that can prevent the virus from producing its machinery needed to replicate. Immune globulin is often the treatment for Kawasaki disease and should be used in patients that meet that criteria. Steroids are going to be the thing that I think is most controversial as to whether they help or not. Tocilizumab, which is an anti-IL-6 monoclonal antibody, is being used quite a bit in the adult world for the cytokine storm that's seen with COVID-19. And anakinra, which has been an IL-1B receptor agonist that is used in Kawasaki disease and other rheumatological illnesses. So we really need to better understand this possible association. There is certainly some endothelial inflammation. There could be a genetic predisposition for why these kids are receiving it. And there may even be something called an antibody-dependent enhancement, in which case the antibodies you're even making to the infection at the time are stimulating further cytotoxic effects of the virus. So I want to pause just for a moment to think about, well, a lot of people had hypotheses for why is it not happening in kids? So are kids not getting the illness? Well, I've just shown you that they were based on data from across the globe. Do they have less ACE2 receptors? Well, no, they're actually getting illness, and that's not been proven. Kids don't have the comorbid conditions like hypertension or diabetes or renal disease. Well, adults are dying without those comorbid conditions as well. Do kids have less reactive immune systems? It would seem that elderly would have less reactive immune systems, so that wouldn't make a lot of sense for kids. Do kids have these repeated viral exposures that make them less susceptible to severe disease? The idea that you may develop suppressor cells to prevent the florid sepsis and shock. And are kids receiving childhood vaccines? Could there be something with the vaccines that's helping? So I put this slide in there mainly because I think it's really important to put into context this pandemic. There are likely three scenarios that we will fall into. Scenario number 2, where you see the huge peak that happens, this is sort of the fall surge. This is what happened in the 1918 epidemic of flu. There was some priming. There's even things called the antibiotic-dependent enhancement that were happening. There were higher case fatality, higher mortality that occurred. It's also possible that there could just be a slow burnout of this. This is all going to be in context of what we do with social distancing. I could probably spend at least an hour talking about vaccines and the development of vaccines. I'm not going to do that, but I do want you to be aware that there are over 115 candidates right now for vaccine. And these include all kinds of different technologies for vaccines. Some of them being really interesting is messenger RNA or different viruses such as the chimpanzee adenovirus, which doesn't cause disease in humans, being a vector for delivering vaccine. And so I think it's important to recognize that there's a lot of vaccines out there. There's a lot of hope for them. I'm not sure that they're going to make it here in immediate time before the fall. Why is that? Because there's a lot of challenges here. There's actually recent data showing genetic mutations in spike protein. That's a protein the virus uses to enter the cell. The specific mutation called D614G can actually, the theories behind this is it either increases the affinity of the connection between the ACE2 and the binding areas, could appropriately improve fusion at that body, or there could be also this antibody-dependent enhancement. In addition to that, this is what we call antigenic drift, where the virus changes some protein structures during the length of its infectious period. So this is where things like flu only tend to happen for a few months and you see less of this drift. But given the length of this pandemic, it allows the virus time to have this drift or shift through even before a vaccine is available and during the time that the pandemic occurs. Also is emerging is a concern for recombination. This is actually at the level of the cell where they share nuclear information together, and it can only happen if host is infected with 2 different viral strains. And so this hasn't been proven yet, but they have seen information that's concerning that recombination is happening. And this is the idea that a more virulent strain could reinfect you after you've already had COVID disease. I bring this up because this was such an interesting theory, and I think it holds quite a bit of information and promise. So MMR, so measles, mumps, and rubella vaccine, the old new hope. So there was actually previous data that measles shares a lot of similarities with the fusion protein of the original SARS virus and also now with SARS type 2. There is demonstration that rubella has homology with certain proteases that have these surface residues that are recognizable to immune cells through MHC1, and they're able to create antibody responses to that. And this group actually looked at cases of people who were admitted to the hospital with moderate versus severe disease and found that rubella titers actually went higher in those who had more severe disease or higher viral loads of coronavirus. So there's also this theory that live attenuated vaccines could stimulate myeloid-derived suppressor cells, which could dampen immune responses of sepsis. So there was ecological data from the MMR vaccine rolled out in Germany, Italy, and Spain. And I'm going to show this to you. It should be clear that pregnant women actually got vaccine first to prevent congenital rubella syndrome. And then different countries had different rates of vaccine coverage and dates of rollout. So what this looks at, this is actually looking at different age ranges across different countries. And MMR is only recently in the sense that there are older people that never received MMR. And those are the people who are dying from disease. So it's a plausible hypothesis that needs further testing. In addition to that, if you actually look at different states, or I'm sorry, different countries and the rates of their MMR coverage, it correlates with the amount of death per 100,000 population, suggesting that MMR vaccine could be protective. This is exceptionally important in the United States if we see a lot of vaccine hesitancy. And in 2019 going into 20, we've seen the highest rate of measles outbreaks. Because of this, in the early 2010s, sailors and also all armed forces received the MMR during their matriculation into the Army and Navy. So this was a natural experiment that occurred where COVID-19 went through an entire vessel, the USS Roosevelt. Approximately 1,000 sailors were infected with the virus, and they had recently received MMR vaccine. It was found that only one patient did die and was hospitalized, but typically in that age range, you would see hospitalization rates somewhere between 14 and 20%, suggesting about 100 people should have been hospitalized from that outbreak alone. With that, I'm going to turn it over to Phyllis to discuss some of the broader implications of COVID-19 in pediatrics.
Thank you, Mike. That was great, and it puts it into context. Now, if it were only for the physical manifestations, as we said, the pediatric population is infected, but doesn't necessarily show evidence of severe disease in many cases. So what are other contributing factors that may impact a child despite not being physically as ill? One of the concerns is neglected health maintenance, and Mike just talked about vaccines. Will follow with that. School closures, food insecurity, behavioral problems, child maltreatment, disparities, and provider challenges. Our pediatricians are also seeing the impact of this disease in other ways, in economic ways. So I'm not sure why I can't go for it. Yes, here. So Mike talked about measles, and measles appears to be on the rise, not only in the US, but in other countries. And here in the Democratic Republic of Congo, can see that there's a surging worldwide impact of measles. The problem with this is that as kids get more cases of measles, then maybe they're losing out on the protection that may be available from that vaccine, and that will be part of the conversation later. Another interesting bit of information that we received from KidsNet, which monitors Rhode Island rates of vaccinations, it's really striking to see that since the COVID epidemic has begun, although the kids are not sick, their families are afraid to take them to the physicians for their routine care. And you can see here, the rate of MMR vaccines are 40% less than they should be at this time. And other vaccines are even more impacted. The only vaccination levels that were increased were those of influenza. If we look more globally at neglected health maintenance in Italy during the COVID epidemic, at the peak of the epidemic, you could see that compared to rates of pediatric emergency visits in the prior 2 years, the rates of emergency visits were drastically reduced. And when you think about that, people are not going in even for a disease that they used to consider an emergency. And that's a huge problem for health maintenance. In Rhode Island, if we look at the rate of hospitalization, currently, this is their data from today, we're only at 70% occupancy in the adult population, which is not at all our normal range, nor is it for pediatrics, we're at 55%. Today, when I checked in the emergency room, there were only 11 patients waiting to be seen. It's a great time to go to the emergency room. The Hasbro clinic visits are also significantly reduced. We expect around over 2,000, and we're only seeing 1,500, if that. Referral to subspecialists at our center are greatly reduced because people are not taking their children to be seen in hospital. So therefore, they for a problem, and therefore they're not referring them to subspecialty clinics. Another very challenging aspect of this disease is that one of the measures that was taken to prevent further spread of the disease was to close schools. And in some ways, it's not exactly clear whether that is something that is of great value. We will discuss this a little bit. As of March 2020, studies showed that over half of the global student population was essentially out of school, with over 107 countries closing schools. And in April, you could see that the difference is even more stark. 90% of the school population is impacted. So what is really the goal and the accomplishment of a school closure? So a big meta-analysis was done by Dr. Viner at the London School of Public Health, showing the evidence that exists. So there is some evidence that you could reduce, for example, outbreaks, the peak of an outbreak and the peak of the delaying in the peak. So sort of flattening the curve. That was a study reviewing SARS outbreaks of the past. But the challenges with school closures is that, in fact, it's not necessarily impacting as well depending on the virus. So if you have a reduction in the transmissibility that is low, so if you have a low viral transmission rate, that school closure can have an impact. And also, if the attack rates are higher in children than in adults, you can have a lower impact. We don't actually know for SARS-CoV-2 whether or not the attack rate is lower or higher in children, because we don't have sufficient testing to know this. And, you know, as we close schools, we lose access to the important resources that are available to schools, obviously. In SARS-CoV-2, it seems that our transmissibility is actually quite high. It's in the order of 2.5 to 3.5%. So it's unlikely that this school closure would have a significant impact on the rates in this context. Also, another important caveat that was found by others is that many of the students find a way to still interact with each other off-site. What about the impact of school closures on the caregivers? So maybe the children aren't getting sick. Maybe we don't know what the transmissibility is. However, who takes care of the children that are now left at home? And that's a real significant problem. In the US, 30% of our healthcare workforce have small children, aged 3 to 12, that require someone to watch them. with the closing of daycare centers, of after-school programs, of school programs, that has had a tremendous impact on the healthcare workforce because they have to find a way to care for their kids. Same statistics in the UK, plus minus, compared to the rest of the workforce where the caregivers are not necessarily as much tied with as with the healthcare workers, for example. So on the right, you see this graphic showing that what may be the impact of this absenteeism, perhaps, of healthcare workforce. So if the healthcare workforce moves away from work because they have to care for their kids, the challenge is that one may see increasing impact on patients in hospitals if there are not sufficient providers. Whereas you may not see a benefit in the number of cases avoided. So we are somewhere here where it's not clear whether this strategy is going to work if we impact healthcare workforce. So in a recent modeling study that was done for the SARS outbreak, 4 or 13-week closures did minimally impact the attack rate, but also markedly impact the national economic costs and the impact on healthcare workers. Another significant challenge with this epidemic and this pandemic is food insecurity. Prior to COVID-19, you can see that food insecure households in the US were about 11%, with very low food insecurity being around 4.3%. Now, the Hamilton Project provides a lot of information and data regarding food insecurity, and recent statistics are stark and very alarming. Prior to COVID, we were trending slightly down in terms of food insecurity for families saying that the children did not eat enough or the food that was bought didn't last enough. But the data from April 2020 is absolutely astounding in terms of food insecurity at even the gravest levels. So here you can see up to almost 15% when it had been about 4%. So this is a very significant concern. And these data are shown again here where prior to COVID, in 2018, very relatively low rates of food insecurity at the highest levels, but this is where we are in April of 2020 with very significant increases in levels of food insecurity. Of course, when people are stressed and kids are at home and there's a lot of insecurity, there's concerns around behavioral problems. Of all the places I showed you, we were having very low hospitalization rates and visits to the clinic. The only exception to that is at Bradley Hospital, which is full, and at Hasbro Children's Hospital, Celia 6, which is the 6th floor where we keep kids with behavioral issues as well as medical conditions with behavioral components. And this is what's happening is that these kids are sharing that their conditions are being made worse with this epidemic. This is a study out of a group called Young Minds in the UK, surveying 2,000 participants of age less than 25. You see 83% said the pandemic made their condition worse. 26% were not able to access their normal support systems. Their peer groups were canceled, and some people, and maybe I'm one of them, can be challenged by other modalities of interaction with people online or with Zoom or whatever. And there are privacy issues that come up with these things. So overall, the feeling was that kids had much worse mental health, a bit worse, or at most no difference, but very few felt better in the case of COVID. Interestingly, this was a quote that was listed in that study, which said that some child said, "My school shut down. I've been FaceTiming with my friends all day, and this made me realize how much I was really loved. Also, it has given me time to improve myself. So some kids actually are introverts or are bullied at school and may see the benefit of isolation, but not as many in the grand scheme of things. Another important thing is that obviously children who are left at home and parents who are stressed with social isolation, loss of job, financial strains, other illnesses, worries, other problems, loss of protective supports, and an active, unruly child with increased behavioral manifestation makes for a perfect storm. Even a child who is not in any way difficult, but to be stuck in a home with a stressed parent who has significant issues can lead to an increase in physical abuse, and that's been well documented. So that's the perfect storm for increased maltreatment. So what have we seen? Actually, we've seen fewer cases of maltreatment, not because they don't exist. It's probably because they're underreported. Who typically reports child abuse? Mostly people at schools, educational personnel, social services. All of these services have been discontinued or limited, so these cases may go unnoticed and unaddressable at this time. So this is a very concerning issue that has come up. I'd like to spend a moment talking about disparities in COVID-19 as well, because a recent study just came out from the London School of Hygiene and Tropical Medicine, where they looked at the largest analysis of patients on record with COVID across Great Britain. There were 17,000 plus adults who were essentially seen between February and April. And in this study, they focused on death in hospital. What they showed was there were over 55 or 5,600 deaths attributed to COVID. And despite all regressional analysis for age, sex, and covariates such as obesity and smoking status, etc., they found that there was a strong association with being Black or being Asian as a risk factor for having death as a consequence of COVID in this adult population. Now, it's very easy to say, well, it must be a genetic problem. However, the reality is that there's so much admixture that it's difficult to pin it on that. And I would say that the fact that in Great Britain, being Asian predisposed you to worse outcomes suggests perhaps unconscious bias and other concerns about how healthcare is delivered for various patients. So that's something to keep in mind. But all of this causes an increased health burden, of course. What about Rhode Island? If we look at the demographics in Rhode Island, the biggest areas of population that have COVID positivity are Pawtucket, Central Falls, and Providence. So I'll just talk briefly about Pawtucket, Central Falls, 2,500 per 100,000 population cases of infection. And remember, we don't really have a denominator. We don't know how many people actually have it because we haven't tested everyone, and we don't know if there are disparities in testing. However, the rates are high in these communities, and if we look at the rates of hospitalization by race and ethnicity, this is data from the Department of Health, you can see that despite there being only 16% overall total numbers of Hispanic Latinx in Rhode Island, 44% of the cases are attributed to this population, with 33% hospitalization. Thankfully, the rates of death are no higher than the population rate. Similarly, in African Americans, you can see again, only 6% of the total Rhode Island population, however, 13% of hospitalizations and cases here. So of course, our minority families are feeling this much more than the rest of the population. For the case in Providence, as you all know, is a majority minority city with 16% African Americans. Compare that to the statistics across the state, where it's only 6%, and Latinos who are in Latinx who are 38% in Providence, whereas in the rest of the state, it's around 13-14%. So a lot of people do not speak English at home. And again, so we can then better understand these demographics and saying that probably the fact that these individuals are not dying but are affected and hospitalized is that they may be a younger cohort of patients. And therefore, they may be more the folks with young families. And what happens when a provider is sick, incapacitated, hospitalized, and what happens to the children? This is also just reflecting that same demographic, that in 30% of all of our non-white population in Rhode Island is young. The older generations are the white population. So it is, these statistics here on the right are perhaps have to be understood in the context of how the population looks in various parts with high infectivity, such as Providence. So last, I'd like to touch briefly on providers. So pediatricians are notoriously known for not being well remunerated and for seeing less reimbursement from Medicaid as compared to Medicare. They also have significantly lower payers than other states that surround us, for Rhode Island, for example. This is data from the American Academy of Pediatrics Rhode Island chapter. They asked a question to the providers: over the last 4 years, has your take-home pay increased, decreased, or not changed? And you can see the stark reality. That was even before the COVID crisis. And when asked after the COVID crisis, have you had to reduce your workforce? A large proportion of people answered yes. Another, of course, are we worried? Are pediatricians worried? Extremely worried, because their practices are closing or are at risk of closing. Most patients are now seen by telemedicine, which is good because we're getting reimbursed for this, but there are patients who are afraid to come in and are not seen at all. In fact, even before the crisis, 2 practices in Rhode Island closed because of a lot of concern financially, and that displaced 5,000 patients. And here are some poignant quotes that I won't go into too much detail, but a person who was here for 24 years, I lost my job because of this. Because of COVID, our patient visits went down incredibly. We couldn't afford to keep me. And others who have been here 35 years also have had very sad moments about possibly closing the practices because of this crisis. Rhode Island practitioners are usually somewhat older as well and had been contemplating retirement, and now there's very little incentive if their practices can't recover. So in summary, for what we both have said, all ages are susceptible to SARS-CoV-2. And children may have fewer respiratory manifestations and death, but they still have disease. And we're worried about the emergence of this new disease that may impact them at a significant level, as we're seeing across the country. We are actively monitoring. What are some of the short-term protections that may be offered? We'll see whether we can come up with vaccines, et cetera. In terms of everything else, would we be seeing a return of other illnesses such as measles, as no one or very few people are getting vaccinated for these for this virus? Disruption in education, potential for maltreatment, health disparities, and financial impacts on providers. Some solutions, perhaps, and maybe that will come up more in the questions. Can we anticipate? So that's what we're doing in the Department of Pediatrics, anticipating the presentation of this late manifestation. We're trying to advertise that we are open for business. We can see patients. It's safe to come into the hospital. Are there ways to have alternative care? If not, and in some states, they've been administering vaccines drive-by or seeing kids in health vans. Are those possibilities? Is there a way other than school closure to socially distance, to limit group gatherings at lunch or something? Luckily, Rhode Island is a state where we feed kids. Despite this crisis, there are lunches and meals available through the public schools. And in terms of our disparities and our messaging, it's important that we provide the appropriate signage to advertise, to maybe utilize our resources that we have through Lifespan Community Health Institute or Dunkin' Donut vans to reach out to communities. It will also be very important to get the denominator. We don't know how many people are infected, and a lot of our disparaged communities that are not able to get to a testing site will never get tested. And we have embarked upon considering a survey at the Hassenfeld Child Health Innovation Institute from the birth cohort to look at the impact on families of healthcare services. For maltreatment, I'll refer you to a bunch of resources that are available: a Safe at Home program, reading programs, PSA to parents, working with DCYF. And for providers, realize that although we're paying for telehealth visits, the EOHHS does not pay for a second visit in person after social distancing. They have not approved that, whereas other states have. And if there is a way to enhance the payments that are available to non-Medicare providers through various programs such as FMAP or the CARES Act, which right now has only provided relief to Medicare and not Medicaid. So there's a lot for us to do, and we have a lot of concerns in pediatrics, despite the fact that we don't have as many patients who are coming in the ICUs. So with that, I want to acknowledge our Department of Pediatrics for providing all of this important information. I'd like to thank Pat Flanagan, who has really challenged us to bring this conversation afoot. Gregory Fox from the Rhode Island AAP, our leaders in the Child Abuse Center, the Aubin Center, Christine Barron and Brett Slingsby, our folks from DBP, Pam High and Davina Savant, who is a fellow who talked about food insecurity and helped me with that. Our folks from the Lifespan Community Health Institute, Carrie Bridges Phyllis, the director, as well as Andrea Celli, the program coordinator for the Injury Prevention Center. Every day we hear from Nicole Alexander, that we proudly claim has trained at Brown and is our infectious disease specialist, and the leadership of the Hassenfeld Institute as well, with Erica Werner and Patrick Vivier, who have provided some insights into this conversation. So with that, I will stop and happy to entertain questions. I know there are a bunch on the chat. That's the word. Yes. Thank you.
Very good. Thank you so much, Phyllis and Mike. That was just absolutely fantastic. We all learned so much. Do you want me to read the questions, or do you guys want to read the questions?
Why don't you? And you can sort of summarize, I suppose.
Okay. Well, I think this one's probably for Mike. Could you speculate on the reason for the delayed appearance of the syndrome of toxic shock, as it were? Is this at all similar to delayed compensation of pulmonary status that's been reported in adults, or is this unique to children?
Yeah, I think it's probably following some of the similar mechanisms of cytokine storm. And, you know, it's not fully elucidated. We don't know why it's happening. I think speculation is what it is, but it is a delayed response that is probably mediated through some either antibodies or mediated through some additional cytokine trafficking that occurs. I don't know much about the adult condition to know how well related they are, except to say that it appears that some of the treatments might be the same, like IL-6 blockade.
Another question.
I'm sorry, Sharon, that has been reported in kids that they have, there's at least a couple reports of kids having high IL-6 levels.
Do you know if the pediatric multisystem inflammatory disorders has been reported in other countries with earlier severe epidemics such as China, Italy, and Spain?
I haven't heard any reports out of China, but yes to Italy, yes to Spain, yes to most of the European countries. And haven't heard anything from China at this point. And it looks like across the country, a few cases, but New England seems to be the main one. And you know, if I get to speculate about things, I might even think that may have to do with the virulence of the different spike proteins, possibly. Being that maybe some of the European invasion came more towards New England versus Asian influences on the West Coast. So, but no one knows that for certain.
Okay. Let's see. Here's you talked about the possible protective effect of prior MMR. Is there a correlation with obesity in the delayed shock syndrome in children?
Not that I've seen, though I do want to know what their MMR status was.
Okay. Okay. There's been talk about recent vaccinations offering broad viral resistance. You had mentioned the possibility of considering changes in traditional immunization schedules. Could you elaborate on that?
I don't think I mentioned any changes in the traditional. I still recommend those. Though I would say that there's possibility that MMR, for instance, could be used in a, potentially as a trial in the United States for high risk folks, including healthcare workers. There was, I think, a question about BCG, which is also a live vaccine, and that's being used in the Netherlands and Australia already in randomized controlled trials. It likely only lasts a year, and it's thought to be more through that myeloid-derived suppressor cell than through, I think MMR holds even greater hope. They're both safe vaccines. We already know they're safe. And MMR holds more promise, I think, because of the receptor similarities in measles and these residual binding residues that are on the surface of the coronavirus that rubella antibodies seem to be able to neutralize as well.
Okay. Of all the places that SARS-CoV-2 RNA has been found, are they being tested for infectivity and any changes in the RNA from upper airway to feces?
So 2 great studies show that after about 8 to 9 days, you'll no longer have viable culture, meaning it will not grow, viable virus. It will not grow in culture after 8 to 9 days. So presuming from that you're not infectious after 8 to 9 days. The PCR can last out much longer because it's detecting potentially dead virus. So far, only PCR has been reported in the stool. There's been no virus isolated from the stool, which is in contrast to SARS-CoV-1, where it was isolated from the stool by culture.
Okay. Are levels of COVID-19 antibodies higher in pediatric patients or in the patients presenting with the severe illness?
Yeah, we don't have any data on that yet. I think this has been a big problem in terms of the rollout of antibody testing. They allowed way too many tests to come in that were not validated. It's been a big problem. I would say Mount Sinai is on the tip of this, having one of the best antibody tests for people that care.
Here's an interesting one. I'm a 63-year-old physician. Should I update my MMR? Given waning immunity.
Yeah, I mean, this is the data out of Cambridge that did show that there's possible benefit to MMR. This is preliminary information. It's a safe vaccine. I mean, I don't think there's any danger to it. When I think about vaccines, I think of 2 things, safety and efficacy. I can tell you it's safe. I can't tell you whether it's effective.
What about BCG in adults or in all age groups?
Yeah, so again, we don't have that in the United States readily, mainly because we don't have TB. In other countries, as I mentioned, Netherlands and Australia, they've already started randomized controlled trials for that in healthcare workers. The difference there is that the way that primes the immune system typically only lasts for 1 year.
What about transmission through blood from, say, mother to fetus or through blood transfusions?
not documented.
Okay, here's a little bit about telehealth. Looks like, yep, they're doing pediatricians are doing telehealth. Um, uh, ooh, this, Phyllis, what are your thoughts on early childhood education services, 6 months to 5 years old? What would be the ideal conditions for centers to operate while monitoring children who are possibly infected and protecting educators?
The challenge with all of that is that we don't have a good, we've had an improvement in our availability of testing. However, we don't have rapid, readily available testing throughout. So it will be very difficult to know where where is it safe and where is it not. We found that in our environments, one time we had a patient who came in and was positive, but had not been tested yet, or didn't show symptoms till a little bit later, and a whole floor had been exposed. Because of PPE usage and careful hand washing and appropriate precautions, not one of the caretakers, not one of the healthcare workers got sick. So it suggests that we could mitigate the risk of infection with careful hand washing and careful with appropriate PPE. But would that be available in the schools? I really doubt it. Someone asked a question about masking the kids. That's a very challenging proposition to mask kids because they are they don't tolerate the masks, and in some behavioral kids that's a challenge too. So don't know if there's a way to do this safely to prevent infection, but whether we need to think that that's going to make a huge difference to keep kids away from schools is not clear yet.
What about visiting nurses doing door-to-door MMR vaccination?
Mm. That's a good one. Mike, you want to take that one? I don't think that we have those resources available, unfortunately, and we have not yet gotten to the point where we're even providing vaccinations as an opportunity to do offsite as have other centers. Some of the pictures I showed were in the US where people were doing drive-by care, vaccination, etc. We are not there in Rhode Island yet.
Yeah, MMR is challenging because it's a live vaccine, so it has a certain cold chain supply that you need. But for other vaccines, it's certainly, I think we're open to anything to improve child health. And I think Phyllis even mentioned things like the Hasbro bus and other ways in which we try to provide community care. I mean, we care about access for kids here at Hasbro, and Phyllis highlighted a lot of the issues around social disparities and things like that. And so it would make sense for us to try to do our best to mitigate the access. The real issue is we have the vaccines, we're a medical home, we're here, we're able to provide them, and patients aren't getting in. So I think there needs to be probably solutions that target, the marketing, some of the marketing issues that Phyllis brought up in terms of coming into the hospital and getting your vaccines. But we should try any way we can.
Yeah, I think that we really have to now move to this next phase to try to see if we can encourage providers to refer back to the hospitals, to refer to our subspecialists, for providers to see the patients. I think the fear is there and continues to be there, whether it's on the pediatric side or the adult side. One anecdote is, for example, for mammography, totally different topic, but only when this service was reinstituted, only 25% of the patients agreed to come in for a mammography, which means that everyone is running scared and everyone is still concerned that they'll come to the hospital and get sick, which is not the case.
What about telemental health for children? There has been work with that on adults, for adults.
Yes, I think that I wonder if one of our participants could comment specifically on that, but we have been doing telehealth for all aspects of health. I think that we also have the inpatient wards, as I said, that are not that are full at this time, and whether it's at Bradley or here. And we have not seen a decrement in those kids, and they come in pretty dire straits as well, with behavioral challenges. I wish Pat Flanagan could comment, but I'm not sure she can with this forum. But if you write it in a chat, I'll talk about it. But it sounds like we need to consider these options. But with our patients, I was expecting to see a real large decrement in the number of missed visits, for example, in setting up telehealth, because what's easier? You just go and you get telehealth services. You can just call in, but people are stressed, and some people forget, and so our rates of no-shows are still there, and it isn't always facilitated by the availability of telehealth, depending on the stressors in the home.
So I'm going to move back up. When schools reopen, what about temperature screening upon entry to the school, and how to do it?
Yeah, if a lot of people are asymptomatic, I'm not sure what that screen is going to do.
Yeah.
To be honest, we have seen screening, a proposal for screening at the airport for temperature. But again, there's a lot of caveats there, because a lot of people shed before they're even symptomatic. So it's not clear to me that would be a very useful strategy, and whether it's worth the bother, so to speak.
Could you, either of you, comment on skin changes in children, toes, rashes, etc.?
Yeah.
I mean, we see, just like any virus, you get a petechial rash, you get some other kinds of rashes. The Kawasaki-associated, issues come with rash. COVID toes we haven't seen as much in kids. It's not been, from the dermatological reports and things, it hasn't been as common in kids. But it exists out there as an entity. These are all, COVID toes are very, very rare still. So those are the main skin manifestations that are presenting. I would say the ones, especially when you think about this pediatric multisystem inflammatory syndrome, is that rash is coming along with fever and prolonged fever. So oftentimes like 3 to 4 days of prolonged fever. And so it's not very subtle to parents. When you have a rash and fever, it scares them. They're going to seek care for that. So I think the skin findings aren't as subtle. The COVID toes is a little bit different phenomenon that people haven't worked out yet, but I haven't seen it yet in kids, and I don't think we've seen it here yet in Rhode Island, but it's clearly well described in the dermatological literature.
Can I just now come back to the question about the behavioral health telehealth issue? Yes. So a resounding yes from many people who say that they are conducting telehealth, but the higher percentages in person for behavioral health, but mental health services are provided in person and virtually in many environments.
Great. So there's a lot of this story about the crew of the USS Roosevelt is absolutely fascinating. Are they being studied intensively now?
Well, I have to give a big shout out to my friend Lloyd Fite, who's a cardiologist, and tipped me off to that, what had happened on the ship. But following up on the basic science research was where it got very, very interesting. And so I haven't heard anything more about the sailors that from the Navy that were on that ship. I don't think more have gotten ill. I don't think any more have been hospitalized, but we'll see. I mean, I think that you can imagine that, Walter Reed and other programs are interested in looking to see what happened there, but we have nothing reported yet.
Okay. Okay, lots and lots of compliments for both of you in the chat. We thank you so very, very much. This was just a very informative and also a talk, and also gave us a vision of some of the challenges that families are going to be facing going forward. So, and providers as well. So thank you so much.
Thank you for having us. It was great fun to do this. Thank you.
Great.
Thank you, Sharon. We're always delighted to talk about kids.
Okay.
Yes. Thank
Bye-bye.
you. Bye.